Cervical and lumbar traction. Traction is a technique that applies a longitudinal force to the spine and associated structures, thus distracting the vertebrae. The distractive forces can be administered by gravity, a machine, a clinician, or by the position of the patient's body. The longitudinal forces can increase space between vertebrae, decrease pressure on intervertebral discs, decrease pressure on spinal nerve roots, open facet joints, and elongate soft tissue. Traction forces can be applied with either a continuous or an intermittent tension. This is an example of traction at the hip joint. This is a longitudinal pull. This is an example of traction at the spine with a longitudinal pull along the line of the spinal column. During the spinal traction, the facets glide apart and the foramen opens. The Clattenborn Traction Grading Scale. The Clattenborn Traction Grading Scale is used to grade the levels of traction. There are 3 grades of traction. A grade 1 level traction is used to loosen structures. This neutralizes pressure in the joint without actual surface separation. This level of traction produces pain relief by reducing compressive forces. Grade 1 traction should be used initially to reduce the chances of a painful reaction to traction. A grade 2 level traction occurs when you take up the slack of a joint. This separates the articulating surfaces, taking up slack or eliminating play within the joint capsule. It is used initially to determine joint sensitivity. A grade 3 level traction causes a stretch. This involves stretching of soft tissues surrounding a joint and also causes an increase in mobility in hypomobile joints. A grade 3 traction should be used in conjunction with mobilization glides for hypomobile joints to increase range of motion. The 2 primary types of traction are cervical traction and lumbar traction. Traction is indicated in conditions in which the patient's pain is caused by mechanical pressure on the vertebrae, facet joints, or spinal nerve roots, or other conditions in which removing mechanical stress results in pain reduction. Traction was previously prescribed in conjunction with immobilization and bed rest for spinal and back pain. The current uses of traction commonly emphasize the use of active exercise with traction to provide short-term mechanical relief of pressure placed on nerve roots, articular facets, and other structures. Continuous traction is performed when a sustained traction is applied with a relatively small force for 45 minutes or less. The tension in continuous traction does not change over the course of hours or days. Intermittent traction is performed with alternating periods of traction forces, with intervals of relaxation in the tension by way of an on-off duty cycle. Manual traction is administered by the clinician. Auto traction occurs when the patient controls the amount of traction. The patient can perform auto traction by using gravity or by specific positioning of the body. The most common uses for traction include disc protrusions, degenerative disc disease and nerve root compression, facet joint pathology, and muscle spasms. For most pathologies associated with cervical traction, the amount of traction needed is much less than that of the lumbar spine. Separation of the cervical spine begins to occur with about 20% of the body weight when the patient is placed in a reclined position. There are 2 primary types of harnesses that are used for mechanical cervical traction: a mandibular occipital harness, which is pictured on the left, and center pictures, and an occipital harness, which is pictured on the right. This table explores the guidelines for the treatment of various pathologies with traction treatment. Please refer to this table for guidelines for treatment protocols. The angle of pull. The angle of the applied traction is described relative to the long axis of the vertebral column and must be appropriate for the pathology being treated. Traction angles are often described as neutral in the transverse plane, flexion or extension in the frontal plane, or unilateral in a sagittal plane. In the cervical spine, the inferior facet joints are angled anteriorly. In the lumbar spine, they are angled posteriorly. Placing the cervical spine in flexion opens the facet joints and increases the intervertebral space. But too much flexion will result in a decrease in the anterior space available. To open the intervertebral space, place the cervical spine in approximately 25 to 30 degrees of flexion. To separate the facet joint surfaces, the traction must be administered in at least 15 degrees of flexion. In the seated anterior lean position, the patient is seated in a chair and leans forward. The vertebral separation is significantly increased. Because the lumbar facets are angled posteriorly, placing the lumbar spine in extension will open the facet joints. When the traction is applied in the neutral position, the intervertebral disc is allowed to elongate. The effect and effectiveness of traction is related to the position of the body part, the position of the patient, the force and duration of the traction, and the angle of pull. To distract the vertebrae, the force applied must be sufficient enough to overcome the sum of the resistance of the weight of the body part being treated, the tension of the surrounding soft tissues, the force of the friction between the patient and the table, and the force of gravity. The amount of tension applied to the body is expressed in terms of pounds or kilograms, or as a percentage of the patient's body weight. Once the force overcomes the effect of gravity, friction, and body weight, the force is then absorbed and dissipated by the patient's muscle tone and soft tissue tension. The difficult thing with traction is there is really not a good formula to use to determine how much traction to apply to each patient. A good rule of thumb is to use the least amount of weight as possible in order to relieve symptoms. Less force is needed to distract the cervical spine than the lumbar spine. The vertebrae closest to the source of traction require less force to separate than those further from the harness, so it is important to know where in the spine you are trying to create a distraction. This is a picture of a typical mechanical cervical traction unit. There are multiple factors that are adjustable, including the angle of incline. Again, more or less incline is needed to create distraction in different areas of the cervical spine. The hand pump creates the tension, and a quick release button allows the patient to release the traction. As we all know, more traction is not always better. Too much force can cause muscle guarding or can cause further injury of the soft tissue. Vertebral separation begins when tension is equal to 7% of the patient's body weight. There is a significant increase in the opening of the intervertebral foramen between 5 kilograms and 10 kilograms of traction force. However, there is no additive benefit when the force is increased to 15 kilograms. Excessive force applied to the cervical spine during traction may be transmitted to the lumbar area via the dural covering of the spinal cord. This can lead to residual lumbar nerve root impingement and subsequent pain. Contraindications for the use of cervical traction. Contraindications associated with spinal traction include vertebral fracture or dislocation, disease, infection, or tumors that affect the cervical vertebrae, hypermobile joints, severe disc herniations, rheumatoid and osteoarthritis, vertebral artery dysfunction, and dizziness during treatment. With lumbar traction, it takes a lot more force than does cervical spine traction. We must overcome approximately half of the body weight in order for lumbar traction to be effective. A split table can reduce the amount of friction between the body and the table and can be a lot more comfortable for the patient during the treatment. In order for lumbar traction to be effective, the patient must wear a pelvic traction harness and a thoracic stabilization harness that fixates the patient to the table. The lumbar traction can be applied in different ways, either through manual traction, an inversion traction, or auto traction. The primary difference between cervical and lumbar traction is the increased amount of tension required to separate the lumbar vertebrae. The effects of the injury response process. It has been previously stated that more tension is required to separate the lumbar vertebrae than that required for the cervical spine. However, the range of tension used during lumbar traction is quite variable, and the efficacy of various weights has not been established. Among the published literature, tension ranges varied greatly from 10% to 300% of the patient's body weight. Research has established that approximately 90% of the increase in intervertebral separation occurs during the first 15 minutes of static traction, which may help us as clinicians to guide our practice. Lumbar traction results in a decrease in lumbar lordosis, distraction of the vertebral bodies, increase in disc height, stretching of the lumbar muscles, and widening of the intervertebral foramina. Seeing is believing. With cervical spine traction, in these pictures, we can see a CT scan image of the benefits of cervical spine traction. This individual has a kyphotic buckle in the cervical spine, which is indicated by the large blue arrow. Disc bulges and protrusions are occurring into the anterior subarachnoid space, indicated by the 4 blue arrows at the C3, C4 level, C4, C5, C5, C6, and C6, C7 levels. There is a disc compression or dehydration as well in this picture. After the use of cervical traction, there was a reversal of the kyphotic buckle, indicated by the large arrow. Disc bulges or protrusions were all receded into normal ranges. There is still a protrusion at the C6, C7 level, but the others are markedly improved. The flattened, compressed discs have dramatically expanded, appearing thicker, lighter in color, and more rehydrated. The effects of traction on the injury response process has effects within 2 major areas, including muscle spasms and the pain associated with disc degeneration. As far as muscle spasms, traction can be effective in reducing muscle spasm caused by nerve root impingement from the narrowing of the intervertebral foramina, stenosis, or disc protrusions. Traumatic muscle spasms can be reduced secondary to stretching of the muscles. The pain associated with disc degeneration occurs from a nerve entrapment as a result of a disc protrusion. This can be reduced by allowing the disc to return to its original shape, decompressing the nucleosis pulposa to below 100 millimeters of mercury. Radicular pain caused by lumbar disc herniation is reduced with forces of 30 and 60% of the body weight. The contraindications associated with lumbar traction include vertebral body fractures, unstable spinal segments, hypermobility in the vertebral segment, pain of an unknown origin or cause, pain caused by disease, infection, or tumors, and rheumatoid or osteoarthritis. Precautions associated with the use of lumbar traction include severely herniated discs, spondylolisthesis, and spondylolysis.